Please join me in welcoming as our next speaker, Dr. Tom Montine, who's the Alvord Endowed Chair in Neuropathology, the pathology of the nervous system, and Chair of Pathology at the University of Washington. He is a professor in pathology and an adjunct professor in neurologic surgery, the surgery on the brain and nervous system, director of the Pacific Northwest Udall Center of Excellence for Parkinson's Disease Research, and director of the UW Alzheimer's Disease and Research Center. He is a top recipient of NIH, that is federal funding, among all departments of pathology in the faculty of the United States. The focus of his work, and I expect that he'll be talking about it today, is the structure and molecular basis of cognitive impairment in Alzheimer's disease and Parkinson's disease, with the goal of defining what goes wrong and how to identify new potential therapeutic targets. He earned his Ph.D. in pharmacology, the first doctorate at the University of Rochester, and his second M.D. doctorate in medicine and a master's in surgery from McGill University in Montreal. So welcome, Tom, and thank you.
Thank you very much, Mika. Thank you, Mika, very much for the introduction and for inviting me, and welcome everyone to the Midi Medical School. I appreciate you coming and sharing this evening with us. Kate, I think, did a terrific job overviewing a very difficult topic, neuroanatomy and functional neuroanatomy. My goal is to build on that in the second hour, speaking about what are the major challenges to living smart and staying sharp as we age. So, major challenges to healthy brain. This is a graph that I've taken from the IHME, stands for the Institute for Health Metrics and Evaluation, which is an organization supported by the University of Washington and the Gates Foundation. I would recommend to you, if you haven't, to visit their website. It is jaw-droppingly interesting. The IHME has taken as its goals to define the global burden of disease. This graph is the disability-adjusted life years, or DALYs, and this is a measure of how much toll does a particular disease inflict on a given population. So these are the DALYs for the United States. So along the x-axis are the numbers 1 to 25. That means the number 1 to the 1st to the 25th major cause of disability-adjusted life year loss. And on the y-axis is how much that burden has changed over the 20-year period from 1990 to 2010. So number 1 is ischemic heart disease. That means that the disease that inflicts the greatest burden on the population of the United States is ischemic heart disease. And over that 20-year period, we've had some success in reducing that burden, right? Because that bar goes down a little bit. Number 2 is chronic obstructive pulmonary disease, and you can run across this slide. I'll draw your attention to then another way to look at burden is the leading causes of death in the United States, and number 1 is ischemic heart disease, number 2 is stroke, number 4 is Alzheimer's disease. So tonight I'm going to focus my comments on these 2 major causes of brain disease, stroke, or more generally called vascular brain injury, and then the second is Alzheimer's disease. I hasten to add that there are other major diseases of brain that take a great toll on our population. You've heard last week about major depression, so that's in the first red box. Kate mentioned very briefly drug abuse and alcohol abuse. Those definitely damage brain and inflict a large burden of disease in our population. Kate also mentioned Parkinson's disease and multiple sclerosis, and these aren't on this chart. They're less common than these other diseases, but no less devastating to the individuals that have them. So there are many common devastating diseases that afflict brain in middle age and older age. Tonight, as I said, I'm going to focus on two, vascular brain injury and Alzheimer's disease. So vascular brain injury, to review very briefly in this cartoon, the heart pumps blood. That blood flows through arteries and arterioles, shown here in red, to the particular organ, in this case the brain, where they then bifurcate and branch and branch and branch into smaller and smaller vessels, ultimately getting down to the smallest vessels that we call capillaries. And it's at the capillary level, very small vessels, where exchange of oxygen, other gases, and nutrients occurs. So that's where the business of exchanging good stuff and removing waste occurs. At the capillary level, and then as those waste products accumulate, the capillaries form up into larger and larger vessels, into venules and veins, and then the waste products flow away from the brain, right? So arteries and arterioles up to the brain, capillaries are where the exchange happens, and then veins carry the waste products away. So the brain is unlike other organs, and Kate has touched on this already. It is clearly the most vulnerable to reduced blood flow. As Kate said, I think multiple times, the brain is really hostage to the cardiovascular system because it's unable to store sufficient amount of energy on its own. The brain uses the largest amount of blood of any other organ in the body. There's another point to the brain that is different from other organs, and Kate touched on this, that function is highly segregated into different areas of brain. So imagine that you were, for whatever reason, denied blood flow to a small pinhead size portion of your liver, the right lobe of your liver. Well, there would be no consequence to that. You would be totally unaware of it, and there would be no clinical observed consequence to that. It's quite different in brain. Because function is so highly relegated to different regions that even very small lesions in brain caused by an interruption of blood flow can have catastrophic, behavioral and clinical consequences. And I'll show you an example of that. There's a complex relationship then among the heart, the major vessels that come off the heart, course through the neck and up into the brain. The caliber of the vessel involved. Different diseases involve vessels of different sizes, and the risk factors for those diseases are different, and we'll review that in a moment. And then, as I say, the region and the extent of brain damage is also complexly related to the type of vessel, the size of the vessel, and the disease that's involving the vessel. As we move through vascular brain injury, two key concepts are important to treatment decisions. One is that dysfunction occurs and spreads faster than damage. And that's important because therein lies the therapeutic window. So when, for example, someone is beginning to suffer a stroke, it's immediate that there will be dysfunction of the part of the brain that's being denied adequate blood flow. But permanent damage to that region of brain takes minutes, sometimes hours to occur. So there's time, there's not a lot of time, but there's some time to intervene between dysfunction and irreversible damage to brain, and that's essential to modern stroke treatment. The other key point to be aware around treatment decisions is whether the stroke is either hemorrhagic, meaning it's caused by blood spilling into brain because of a ruptured blood vessel, whether it's hemorrhagic or not. And a non-hemorrhagic stroke is also called an ischemic stroke. It's essentially a heart attack in the brain. Right? So it's very important whether the stroke is hemorrhagic or not, because the treatment decisions will vary very importantly on that. So I'm going to show you 2 or 3 examples of different types of vascular brain injury. The first 2 are classic types of stroke. and the third is a less common one. The first one I'm showing here will involve a blood vessel on the outside of the brain. So a large blood vessel that's coming through the neck, not yet penetrated into the brain, but carrying blood to the brain. So a disease of a large blood vessel. The second ischemic stroke that I'll show you is of a small vessel inside of brain, and I'll also show you an example of a hemorrhagic stroke. Okay, so a case study of a large vessel injury to brain. So in the cartoon at the bottom, number 1. This case is a 63-year-old man who presented with acute onset vertigo, so a type of dizziness, nystagmus, which means abnormal movements of his eyes, Horner's syndrome, which is an eponym for a constellation of signs and symptoms that involve the sympathetic innervation of the eye, so lack of tears and an unusual positioning of the eye, impaired sensation on one side, on his face on one side, and impaired sensation on the opposite side of his body, so contralateral pain and loss of pain and temperature sensation. Okay, this is a complicated, for those of you that are students of neuroanatomy, you'll probably get this. This is a complicated set of signs and symptoms, and I use it deliberately because there's only one place in the brain that you could possibly lesion and get this constellation of signs and symptoms. So this is to reinforce this notion that the function is highly regulated to region in brain, and that's like, as I say, that's unlike other organs. So, a picture of the medial aspect of brain, like Kate has just been showing you. And here, excuse me, I'll try to get the pointer to come. Here's the brain, as Kate has shown you and reviewed the anatomy. Here on the surface of the brain is a large blood vessel. It's carrying blood to the brain, so that's an artery. And I show in this cartoon a normal artery. It has an outer wall and then inner wall that's made of smooth muscle cells and other cell types, and then the lumen, which just means the hollow part of the tube where blood is normally carried, right? So the blood's not shown here, just the components of the vessel wall. In a disease that's called atherosclerosis, a plaque, so we're going to talk about different types of plaques tonight, but the plaque of atherosclerosis accumulates in that middle part of the wall. And there are a variety of components of this plaque. It has a fatty component and then a reactive cellular component to it, and they're diagrammed here by this sort of peach-colored crescent. It's important to recognize that as this plaque enlarges, the caliber of the lumen decreases, so the capacity of this blood vessel to carry blood is diminished. And that occurs slowly over time, and we have mechanisms, compensatory mechanisms, to deal with that. What causes the immediate ictus of a stroke is that the plaque is damaged or ruptures, and that stimulates the very rapid formation of a blood clot. So you have to remember, this lumen that's shown here as empty is in fact filled with blood. And when the blood comes in contact with the inner contents of one of these plaques, after it ruptures, very quickly a clot forms, and that blocks blood flow distal to the clot, right? So it stops the blood from getting to the part of the brain that blood vessel normally carries blood to. So this is now not a cartoon. This is a cross-section of this blood vessel right here from this gentleman who I described in the short paragraph. So that blood vessel, let me map it for you then. The constituents of that blood vessel here corresponds to this part of the vessel wall. Here, I'll trace it out. This component there is the plaque. The clear part is the fatty, cholesterol-laden component of the plaque. And this plaque has ruptured. And the dark red part here in the center, here, is the blood clot that formed. So what should be the lumen with blood flowing through it is completely blocked by this blood clot. So that's the cause of the stroke. Then 2 more images. The blood clot is forming here, and the part of the brain I'm now showing you is from right there. Part of the brain called the medulla. Kate mentioned it. It's part of the brainstem, this sort of more primitive part of the brain that's connected to the spinal cord. So this is one half of the medulla. This is the left half of the medulla. This is the, this is the front, this is the back, this is the left side, and then this is the other side of the medulla, and it's obvious where the lesion is. So this is this part of the brain that was irreversibly damaged by blocking this blood vessel. Right, so that is the structural basis of the stroke, and all of these signs and symptoms that this gentleman displayed are supported by that region of brain. So a second example, tragic example. A 78-year-old woman awoke with consciousness lasting only a few seconds, enough to tell her husband, "I have the worst headache of my life," and then quickly lost the ability to speak and eventually became unresponsive. This is an image along this plane here, a coronal plane. So right side, left side, the lesion is obvious. It's hemorrhagic, it's full of blood. In fact, it's all blood. The cause of this stroke was a damaged blood vessel, damaged by a particular disease, in this case not atherosclerosis, something called amyloid angiopathy. Blood vessel was damaged, that blood vessel ruptured, and blood under arterial pressure is released into brain, and that's very damaging. Many, in fact, most individuals survive an ischemic stroke. Hemorrhagic strokes are usually much more damaging, and survival is much lower. So the second example of a type of stroke to brain, I've showed you 2 examples where large vessels are either compromised or ruptured. This example will deal with a small vessel. So I've shown you part of this cartoon before, a normal blood vessel, and then a blood vessel compromised by atherosclerosis. There's another disease that will affect blood vessels in all organs, but brain in particular is vulnerable to arteriosclerosis. So rather than accumulating a plaque in a portion of the vessel wall, as occurs here, and that constricts the lumen, arteriosclerosis is characterized by a thickening of this part of the vessel wall that has the smooth muscles, the muscle cells in it that allow the vessel to contract or relax and change its caliber. It's not simply that it becomes thickened, those vessels become dysfunctional. And so these vessels lose their ability to respond to physiologic stimuli to change their caliber. So it's in fact, quite a malignant change to blood vessels. Here in the box beneath are the risk factors that underlie this type of disease that occurs to larger vessels, atherosclerosis, that's what caused that lateral medullary plate infarct. It's also called Wallenberg syndrome. That's what caused that stroke in the first example that I showed you. Atherosclerosis risk factors, there are multiple ones. The big ones are high cholesterol, cigarette smoking, insulin resistance, and diabetes. Arteriosclerosis, this disease of smaller vessels that are not on the outside of brain, but now the vessels inside the brain. The risk factors for those are high blood pressure, and then again, insulin resistance and diabetes. So an example of the type of injury that occurs to brain from this small vessel disease. This is a picture that we took of a piece of brain using a microscope. So this has been magnified many times. So this stroke, which you look at here and you recognize, I'm sure, is looking structurally similar to the first lesion, the medullary stroke that I showed you. Right? So here's the lesion. It looks structurally similar, but it's thousands of times smaller. Right? So these are size of a pinhead or smaller because the vessels that involved are much, much smaller. As I'll show you in a moment, so that might sound like that's good news. It's really not. And I'll show you why in a moment. So, interventions for vascular brain injury. As Kate said, the number one intervention is to prevent. So I'm taking you back to a different graph from the Institute for Health Metrics and Evaluation. And on the x-axis there is the percent change in the burden of disease in the population that can be achieved by modulating different risk factors. And the risk factors are listed on this axis here. So dietary risk, smoking, high body mass index, high blood pressure, so on. And then they're color-coded by what diseases those risk factors modify. And what I'm showing you in red are for cardiovascular and cerebrovascular risk. So a large part of the burden of these diseases is attributed to dietary risk. Now, that's largely under our control. Smoking, high body mass index, obviously that's related to diet, high blood pressure, high fasting plasma glucose, which is related to insulin resistance and diabetes, physical inactivity, and high total cholesterol. So stroke is a very serious medical event, and the best way to intervene is to prevent it from ever happening. And there's lots of choices that each and every one of us can make to try to lower our risk. I'll take you back to the first slide that I showed you. Ischemic heart disease, which has a mechanism very similar to stroke, but in heart rather than brain. We are succeeding in lowering the burden of ischemic heart disease, and in fact, we're succeeding with stroke as well because of intense efforts to manage cholesterol, to promote regular exercise, and control blood pressure. Prevention won't work for everybody, so then what happens if we need to treat a stroke? So I'm showing you the FAST acronym. FAST stands for an uneven, so the first three are common signs and symptoms of a stroke. So the face is uneven, and you'll see here the smoothing of the nasolabial fold, and the corner of this cartoon, the mouth is drooping, right? The arm or leg is weak. Speech is strange or garbled. If you observe those, it's time, right? The T, it's time to move. So a common way of saying this is time is brain. And what we're trying to underscore there is that there's this window between dysfunction and irreversible damage to brain. So the signs and symptoms appear, and there are minutes to maybe a couple of few hours to try to salvage brain from irreversible damage. And this is very complicated medicine. It requires people that are true experts. There's a terrific stroke team here at UW-Medicine. Lots and lots of decisions that need to get made, but there can be very dramatic rescues. And so it's no longer acceptable to say, well, it's too late, the stroke has started. That's no longer true anymore. In fact, it's time to move. So remember FAST. What are the goals? If it's an ischemic stroke, If eligible, and there's a lot goes into this decision, but if eligible, the goal is to eliminate that blood clot because most of large strokes, at least, are related to atherosclerosis, and so there's the opportunity to remove that clot, either using medicine or in some cases even surgical intervention. But again, this needs to happen within hours, and the stroke teams are primed for this. The whole emergency room is primed for this, but it needs to happen quickly. Hemorrhagic stroke is treated very differently. If possible, the cause of the bleeding, the damaged vessel, is repaired. If that's not possible, then the goal is to control increases in pressure within the skull, because those ultimately can become lethal. Longer-term goals, if someone survives the stroke, then is a rehabilitation, and it's truly magic what rehabilitation medicine can do with people who have suffered a stroke to regain function, even if you can't, even if the window has passed on reclaiming damaged brain, right, before it's irreversibly damaged, there's still a tremendous amount of functional activity that can be recovered through rehabilitation medicine. And then, of course, to minimize the risk of having a second stroke, because if you've had one, clearly you're at risk for a second. I return to this graph that I showed at the beginning. We have talked about the cardiovascular system and stroke and how that can damage brain through this ensemble of lesions that we call vascular brain injury. I'll draw your attention then to Alzheimer's disease. It's the 12th, it's ranked 12th in the United States as a burden, a disease burden on our population. It's the 4th leading cause of death, and I'll finally draw your attention to the height of the bar. It is by far the fastest increasing disease in our population. So the case study for Alzheimer's disease, I struggled with what example to show you, and I decided to use these images by William Untermolen. So Mr. Untermolen was an artist, and his leitmotif was self-portraiture, and he has painted dozens and dozens and dozens of self-portraits. This is a sampling of some of his self-portraits with the year down in the corner. So as a youngish man in 1967, and then we jump to 1996. And somewhere around 1997, his family reported that he started to have difficulty thinking. He progresses in his own self-image through 1998. Somewhere 98 to 99, he was diagnosed with dementia, and then his last self-portrait was in 2000, and he passed away a few years after that. So I used a couple terms there that I want to pause and just be sure we agree on the definition. So chronic neurodegenerative diseases like Alzheimer's disease produce a trajectory of cognitive decline, right? So at first, there's difficulty thinking. With Alzheimer's disease, it almost always starts with memory. Mika mentioned our interest in Parkinson's disease. Parkinson's disease has a different type of cognitive impairment, so it starts with another cognitive domain, not memory. Let's stick with Alzheimer's disease for now. So some impairment of memory, so that's problems thinking. That's how it starts, problems thinking. And then the problems thinking become so severe that individuals have difficulty with basic tasks of living, eating, grooming, navigating through your home, right? So these diseases start with problems of thinking, and then they progress to dementia. And what we mean by that word dementia is that you're having difficulty living because your difficulty with thinking has become so severe, right? So cognitive impairment is part of the progression that leads to dementia, which is very severe impairment. So some numbers. I pulled this graph off the web. It's hard really to comprehend the magnitude of the problem that we face. So on the x-axis is the year, so 2010, 2020, 2030, 2040, 2050. Then the y-axis are the millions of people affected in the United States. And then the color code is by age. So if in 2010 you were between 65 and 74 years of age, people in your birth cohort, around 300 or so thousand people in the United States in that age range, in that year, had Alzheimer's dementia. So not the precursor of cognitive decline, but severe impairment in cognition. So severe, you have difficulties with basic activities of daily living. 300,000 people in that age range, and then it's somewhere between 2 and 2.5 million for people in the 75 to 84 or greater than 84 age range. And then you can follow this across. We're at 2015 now, so we're in the middle somewhere. An increase, it's significant for those that are affected, but in 2020, but you can see what's going to happen in 2030, 2040, and 2050. This will bankrupt our healthcare system. And so there is a clear therapeutic imperative to develop interventions that will stop or slow the progression of Alzheimer's disease. And we and many others spend a lot of time thinking about that. So these numbers in millions, I say, it's hard for me to really understand what that means. I was at a conference with leaders in pharma and biotech, and one of them said that one way to represent the magnitude of the problem is that if by magic today I had a pill that would cure Alzheimer's disease, that pill would be worth more than Google. So there is an enormous need to develop interventions that stop or slow this disease. This is a cartoon from the Wall Street Journal in 2010. They highlighted some of the work that we do here in our centers. I like this cartoon because it very nicely depicts 2 of the 3 common causes of dementia in our population, at least. So the most common is Alzheimer's disease, and Alzheimer used the chemistry really of black and white photography to using pieces of tissue from patients of his to show these 2 structures. One is a plaque. So we talked about an atherosclerotic plaque. Now there's the Alzheimer's disease plaque, and I apologize for that. There are other plaques, but we'll leave that out for tonight. So plaques are these large extracellular structures, and we'll talk about them, molecular basis of them in a little bit. And then Kate was telling you about neurons. This is a depiction of a pyramidal neuron, and within that pyramidal neuron is the second structure of Alzheimer's disease, these structures called tangles, or neurofibrillary tangles, if you've studied this or read about it on the web. These little red dots are those pinhead or smaller size ischemic infarcts that I was talking about earlier. If only one of them were to occur in an individual's brain, then it would very likely not have any consequence. But the diseases that lead to these pinhead-sized lesions in brain affect all of the small vessels in brain. And so you can, if you don't take steps to try to prevent them, and some individuals, sadly, that's not enough, but they tend to, in some individuals, occur in very large numbers. And although they're very small, if they're present in very large numbers, they can produce a dementia syndrome. So you don't present with an acute stroke like we were talking about earlier. It's a slowly progressive decline in cognitive function. It looks a lot clinically like Alzheimer's disease. So Alzheimer's disease with its plaques and tangles, these very small vessel injury to brain. And then the last is Lewy body disease, which is a sort of a general category. The prime example of Lewy body disease is Parkinson's disease. These diseases are the 3rd most common cause of dementia. So I'll show you a graph on this. So Eric Larson used to be the medical director of this hospital. He's now the director of research at the Group Health Cooperative. Eric started a study called the Adult Changes in Thought Study. It's a study of aging brain, and the people who participate are members of the Group Health Cooperative. So to the extent that you in the audience are like our neighbors that receive their health care at the Group Health Cooperative, this data is directly relevant to us. So the question that's being answered by this pie chart is, if I could wave a magic wand and make Alzheimer's disease disappear, how much dementia, right, so how much severe cognitive impairment would disappear from Western Washington? And that's the blue part of that pie chart. It's about 45%. So Alzheimer's disease is a major unmet medical need, and it is the most common cause of dementia, but it's not the only one. So in the red wedge is this small vessel injury to brain that I've been talking about. That's a fairly large slice of the pie. For a disease that we have many preventative steps that we could take, and when you consider everyone in this study was actively receiving health care, so this wedge is at least within our grasp to address today. Then the green wedge is Lewy body disease like Parkinson's disease, and then the light blue wedge is that we can't, well, as Kate said, we really don't understand it all yet, and so there's part of dementia out in the community that we don't yet readily explain. So Alzheimer's disease is the most common of 3 common causes of dementia. It would be wrong for me to leave you with the impression that you either have Alzheimer's disease or small vessel injury to brain or Lewy body disease. That's not how it works, at least in the West. What's by far the most common situation is to have a combination of 2 or 3 of these diseases. The most common combination is Alzheimer's disease plus small vessel injury to brain. And there's a major effort to try to understand if that's just by chance, if those are 2 common diseases that appear to be combining by chance, or if they somehow mechanistically reinforce each other. And the significance of answering that is it would mean a treatment for one might be at least a partial treatment for the other. So these diseases often happen in combination. We don't really understand the mechanistic basis of that, if there's any. As I said, it could be chance. And then the second is to underscore, I didn't say this clearly enough before, we started talking about large strokes, which occur like that. Dementing illnesses are entirely different. No one wakes up in the middle of the night and says, oh, I think I have dementia, right? It's been going on for years, decades. And there's good news and bad news there. It means all these estimates of the burden of disease that I've shown you, those are all estimates for the end stage, for the dementia stage of the disease. It means millions of more people are affected by these diseases. They're just at an earlier stage. So the magnitude of the problem is even larger. But the good news in that, I guess the good news in that realization is that we have, like with stroke, a window of opportunity to treat between recognizing that a disease has started and before it causes serious disability to an individual. We, as I say, we have years, if not decades, of a window of opportunity to treat. We need effective interventions to use during that window, and we don't have them yet. Just a couple more slides. Now to focus, right? So we talked about dementia. There are multiple causes of dementia. There are multiple common causes of dementia. The most common is Alzheimer's disease. So what's Alzheimer's disease? It's not one thing. It has a common constellation of signs and symptoms that we group them all these diseases together as one, but there are different molecular drivers for what we call Alzheimer's disease. So this image, this is the patient that Alzheimer described in, I think it was 1902 or 1903 in Germany. she was severely cognitively impaired. As I say, he studied her brain and used the tools that he had at the time and saw these plaques and tangles, and at the time it was thought to be a rarity, and for about 50 years no one paid very much attention to it, and it wasn't until the 1960s that we realized that this was becoming a much more common disease than we had previously thought. So to sum up decades of research, international efforts now that try to understand the root causes of Alzheimer's disease have identified 23 genetic risk loci. So what's the importance of that? There may be diagnostic value in identifying genetic risk, and I'll talk about that in a little bit, because we would be able to counsel patients on their risk of developing Alzheimer's disease later in life. That's out into the future. What's concrete about studying genetic risk today is it tells us of the tens of thousands of possible molecules that might be involved, it tells us which ones are relevant, right? So we now know of 23 different genes whose products somehow are important in starting or turning the key or pushing on the accelerator for Alzheimer's disease. I'm giving you 4 examples of those genes. So 3 very strongly influence your risk of developing Alzheimer's disease. So strong that they're considered causal. That means that if you are unfortunate enough to inherit a mutation, a change in one of these genes, and you live to be middle-aged, you almost certainly, like 99.9% chance, will develop Alzheimer's disease. So there was a recent movie, Still Alice. This goes by the name early onset Alzheimer's disease or autosomal dominant Alzheimer's disease. These are the 3 genes that cause this form of Alzheimer's disease. One is called APP, the amyloid precursor protein gene. The other 2 are called presenilin 1 and presenilin 2. And I have to give a shout out to Jerry Schellenberg, who was here but is no longer here, and Tom Bird, who I believe has spoke at the Media Medical School in the past, are the discoverers of 2 of these. Then the next is ApoE, and then there's that epsilon 4. So so let me stop for a moment. We each inherit 2 copies of a gene, one from our mom and one from our dad, right? Most mammals have 1 copy, 1 type, 1 flavor of the ApoE gene. So mice have mouse ApoE, and cows have bovine ApoE. Humans are unlike other mammals that we have 3 common flavors or forms of ApoE, and they're called epsilon 2, epsilon 3, or epsilon 4. So in this room, and this is throughout the world, right? So these were mutational events that occurred before the human diaspora out of Africa, and something in the evolution of humans has led us to retain these 3 different forms of ApoE. Some people think we're evolving from ApoE4 to ApoE2, but that's speculation. So there are 6 possibilities, 1 from your mom and 1 from your dad. So you can be 2-2, 2-3, 2-4, 3-3, 3-4, 4-4. Those are the 6 possibilities. I am 3-3. So I received an epsilon 3 allele from my mom and an epsilon 3 allele from my dad. If you have inherited an epsilon 4 allele of ApoE, your risk of developing Alzheimer's disease goes up about 3-fold. And if you have inherited 2 of them, your risk goes up 8 to 10-fold, depending on other factors. That's a significant risk. It is not, in fact, it's the largest genetic risk for Alzheimer's disease. It's not a cause, right? So more people inherit an ApoE4 allele and don't develop Alzheimer's disease, so it's not really useful as a genetic test because more people won't get Alzheimer's disease, but we know that something about that ApoE4 is important to Alzheimer's disease, right? So this genetic discovery is not terrific as a diagnostic tool, but it's extraordinarily useful in focusing our research. Because when the book of Alzheimer's disease is done, there's going to be a chapter on ApoE4. There has to be. Right? There apparently are other molecular drivers. They're either not as common or not as strong as the 4 that I've shown you here, but each one holds an important lesson. So how do these genes all fit together? So Kate showed you images of neurons before. So here in this cartoon, this purple band is meant to be the membrane, the outer limit of a neuron. And as she said, you can go to a smaller level and look at molecules. And so one of the molecules that inserts into this membrane is called APP, the amyloid precursor protein, the product of this gene. So mutations in the gene that encode this protein are a cause of Alzheimer's disease. What happens to this protein is that under normal conditions, it's mostly cut by another enzyme about here. And what's happening in all of us right now, but what happens to patients with Alzheimer's disease with these mutations at a higher rate, is that it's cut differently. That's what these 2 scissors are meant to show. 2 enzymes come and cleave this protein to generate this endoproteolytic fragment that's called beta amyloid. And this is a peculiar protein. It's like none other that I've ever worked with. It loves to stick to things, especially itself. And so it aggregates. Those aggregates are stressful to neurons, and then they ultimately accumulate into very large aggregates, and those are the plaques that Alzheimer saw under his microscope. There's another aspect, at least from the genetics, that we would expect to be important in Alzheimer's disease, and that's the ApoE protein. Now, it's not that there's a different type of ApoE, right? It's not like a mutation. It's that we have these different flavors floating around in the population. So it's not that there's too much or too little. It's that there's this different flavor. And how exactly ApoE is driving the risk for Alzheimer's disease remains unclear. There's lots and lots of research that is focused on this. One aspect, one facet of what ApoE epsilon 4 does, it traffics this little protein out of brain. And E4 does it less efficiently than E3, for example. So it may simply be that in this balance of A beta production and clearance, inheriting an E4 allele tips you away from to less efficient clearance. The last piece of the puzzle of Alzheimer's disease has to do with tau. I mentioned these structures, neurofibrillary tangles. Neurofibrillary tangles are intraneuronal structures, pathologic structures that are formed by this protein called tau. It's diagrammed here. I'm running short on time, so I'll just briefly summarize and say tau is important to those processes that Kate was talking about that reach out from neurons to touch other neurons. And something, we're not exactly sure what, something goes wrong with those, with that mechanism, and abnormal forms of tau accumulate and are transmitted from neuron to neuron. So the clinical trials that we and others have attempted, therapeutic agents have been developed to block that scissor, to block that scissor, to clear that stuff out of brain, to block the transmission. The first 3 that I showed you have been through early to mid-phase clinical trials and have not worked yet. These are the trials you read about in the newspaper. This last one with tau is a trial. Their agents are now being developed, and they will come to trial. And there have been some trials already, yet others planned, either to suppress the activity of ApoE4 or enhance the activity of the other flavors of ApoE. So that's why it's part red, part green. So what's the future? We do not yet have a disease-modifying therapy for Alzheimer's disease. The approach that we recommend, we take going forward is what's called precision medicine. This has been recently adopted by the White House Office of Science and Technology. The way we typically approach this disease now is just imagine the population of individuals there up on top, and we're all different, one from another. That's what the colors are supposed to mean. We wait for folks to come and tell us, and it's usually the significant other says that something's wrong, right? And then we use the limited interventions we have, and more or less of a one-size-fits-all approach, yet we know that the molecular drivers are different in different individuals, but we don't have other options. And so the outcome of all that is that some people derive benefit, when blue gets aligned with blue. So if the medicines that we happen to have aligns with the molecular driver that you have, there's some benefit that's achieved. Lots of times there's misalignment, so there's no effect, and in fact, sometimes there's toxicity from the few interventions that we do have. The idea going forward is that, and I apologize, the exclamation marks mean nothing. They're sort of ghosts in the computer we were unable to purge. So so I should have said that at first. The idea we know about genetic risk, and not so much as a diagnostic, but as to help us understand what is an individual's molecular driver, or drivers. So individuals will be stratified by risk. First, by genetic risk. Environmental factors are important. Sadly, we know less about them, but some comprehensive assessment of risk and stratification by risk. And then surveillance tools, which we have developed, biochemical tests, neuroimaging tests. These are before the FDA and will find their way soon, we hope, into general medical practice. You could say, why bother at this point? And I take your point. Until we have disease-modifying therapy, screening for preclinical disease does not bring a lot of benefit, but we will have disease-modifying therapy at some point, and at that point, we definitely want to be able to screen for preclinical disease. So we have those screening tools in place, and we're ready to go. And then the last piece that we need to put in place is that we don't need just the blue pill. We need blue pills, green pills, orange pills. We need all sorts of interventions that will stop or slow this disease. That's the major gap in our knowledge now, and there are literally thousands of labs around the world that are working on this. So the ultimate view then is if we can align different interventions with the appropriate molecular drivers, we will optimize the targeting and the timing of therapeutics, and that's the idea of precision medicine. So to summarize then, the major threats to brain as we get older, there are these two: vascular brain injury, which can be both acute and chronic, and then Alzheimer's disease. Vascular brain injury, there are different types depending on the vessel disease and the caliber of the vessel. Treatment varies with the type of stroke and timing. And interventions are prevention and fast. If prevention hasn't worked and you're suspicious based on the FAST acronym, it's time to move. Alzheimer's disease is the most common cause of dementia. There's a long latency, meaning the disease starts long before there's cognitive impairment, and that's good and bad. It's often mixed with other contributors to dementia, especially in the older population. There are multiple molecular drivers of Alzheimer's disease, so it's not just one thing. And many treatments are under development, but we have symptomatic therapy, we do not have disease-altering therapy at this point. And then finally, this idea of precision medicine for the clinical and molecular complexity of dementia will require a comprehensive risk assessment that will be keyed, importantly, on genetic risk, preclinical detection, and then therapies targeted to an individual's molecular drivers. So thank you very much for sticking with me and participating.